right, y'all ready? So again, you have a nice little study guide, but there's, just so you know, a warning here on this lecture. There's going to be a lot of tests, not a lot, but a handful, so maybe up to 5, 6, 7, that we may get to use in lab next week. Hope to do at least 1 or 2, but it is part of the testing, which may or may not be in chapter 14. So you may have to go, if you hadn't like dissected the book yet, you go up into chapter 7, maybe back farther. I think it's 7. One of the chapters up front has all the different tests. So they have a lot of good pictures to show you. I think it's 7, yes. It's called the general principle or traditional cultivation and ID. Okay, so if you ever have a question as to what the test means or what are we doing, you can actually go into chapter 7 and you can see the explanation of the test and how it works. So some of those are in there and we'll kind of refer back and forth a little bit, but I'll point out the ones that, you know, hey, this is a good one to remember. This will be one you use, and we'll use it next week in Strep Lab on Tuesday, and then do our ID on Thursday. So we will play a little bit with some of these in lab next week. So your Strep Lab is next week. So typically we're going the still got gram-positive cocci, but with strep it's always in a chain. So staph is clusters, strep is chain, and with intro you should already know that. That should be like, oh yeah, I learned one thing in intro. It was the difference between staph and strep. Hopefully, yeah. All right, so the gram-positive organism, they appear gram-negative in older cultures. So in real life clinical micro, we don't get a whole lot of older cultures, right? We're setting things up one day, looking at them at the next. So most of our stuff is, you know, really 1 day growth and not much more than that. So they always say do a gram stain on something less than 24 hours old. All right, so if we do a gram stain next week on the strep, then it may be more than 24 hours old and it may not be as purple as you would like it. And maybe some of you are now seeing that we did set up the culture 2 gram stain the day before. So I didn't set those up on Sunday. I was doing Sunday a little bit last year. I'd come in on Sunday. I would set them up, you know, before I came in to start on Monday. But yours was set up. So we didn't give you an old culture. And then what's new about some of the strep, especially with strep pneumonia A, and I always say it with the A so that I remember to spell it with an A-E. And some of you English majors may be going with it. Really, it's not pronounced that way. It should be pronounced strep pneumonia, right? But I don't remember the E if I say because to me, you got to put the A to give me the E sound. Anyway. Whichever way you want to come across and say it, you'll hear it both ways, pneumonia, just so I know to put the A-E at it, and not pneumonia, like the condition, right? They're encapsulated gram-positive cocci in pairs. So that's kind of your first big hint as to what we'll be looking at the gram stain with strep pneumo. And I shorten it to strep pneumo, that way I don't have to worry about saying strep pneumonia or pneumonia. Or pneumonia. All right, so here's the gram stain, and this is a strep formation. So chain formation, that's the obvious, and some of you are like, well, okay, so yeah, so hopefully you'll see how some of the decolorization can change, and it's not just a, you know, but what do you got most of there? Purple cocci in chains. Okay, so that's what we're looking for. That's what we'd see if we gram stain and found that. We'd say we got a strep, but we got plenty more tests that we can do to the strep that we don't have to go to the gram stain to figure it out every time. And if you see, here's it is from a broth, and here it is from an agar plate. So when we pick it up off of solid medium, the media, and plate it, put it on our slide, it's not as nice. So this is what I mean by you, the microbiologist, just obliterated your chains by grabbing them up, smearing them across the slide, instead of taking a loop full of broth and putting it on there real nice and easy, and then letting it spread and dry itself. So not the classic, chains that we just saw, but it doesn't look clustery either, maybe down here. But for the most part, you can pick out some chains, and we see that it does have a little bit of length, and not so much like the staph that we looked at yesterday on Tuesday. And so here's a classic strep pneumo gram stain. Okay, so strep pneumo, we're going to learn all about it today. But what you're seeing here is the Diplococci. Okay, so you're seeing them in pairs. And you can see that the majority on this slide are paired. So you're not having to guess, did I just obliterate it from the last slide? Do I have, are those paired up? Well, yeah, I can see pairs, but they're not all paired, but you can pick out some pairs. There's a pair, there's a single, there's a pair maybe. Okay, but usually the classic is, yeah, I can tell that those are definitely paired up. There's not a chain that comes in and has 8 in the mix here. So that is strep pneumo, pairs of cocci, Diplococci, gram-positive Diplococci. So when we get to the, I said, hey, the midterm, when it gets here, and I say, okay, I've got a gram-positive Diplococci, okay, you should be like, oh, okay, where's this on my list? Where is he? Okay. So those are the kind of things that you got that's step 1 of an ID.
So that makes another question. We don't have to spell them by ourselves on that midterm exam.
Unless do you want to learn to spell all these? Because I think that would be like an excellent idea, Mary. That's excellent. Like, just give a blank and say, go at it. Right? And I won't and then not allow this either. I won't let you put an S or an E. Because we all love to spell Escherichia when we get to that. Right? Yeah. Not yet, right? We're getting there. So, no, usually it's set up where you have choices to choose from. Now, I might have all the streps listed and all the staffs listed.
No, I just need the spellings. I can't spell.
Yes, yes, I know. But I think we miss the spell. I think we miss out if we don't spell things anymore. Because, yeah, I had to handwrite something the other day, or I had to type it. I had to type it out. I had to type out Escherichia coli. I'm like, I hadn't had to type this in a while. There, oh, look at there. Spelled it right. Okay, but it took a long time, right? It took like Escherichia, yeah. So you will have to type them sometimes. So you do that, and you won't have memory. I mean, you have to get used to spelling. Okay, so this is a blood culture. So we see this strep pneumo showing up in a blood culture bottle. So when we have blood cultures, they are usually in a box or a case, a machine, and they're constantly under 37 degrees, and they're constantly being monitored. And the machines are set that when it senses the change, that there's a positive, okay, and that means that it's growing in the bottle, so it's producing something that a sensor picks up, and we'll get into that later with the machine. It senses it, and it tells the whole lab that you got a positive bottle, okay? It's usually this big, loud horn or music, because it's what? It's critical, right? When a patient's blood culture goes positive, that becomes a critical result. We need to let this nursing staff or the doctor or whoever's monitoring the patient, we need to let them know, which usually is a phone call. Okay, I know that's hard to believe, but we still pick up the phone in the lab and actually call and say, I need to report a critical blood culture positive result on patient in 110, right? Or give a name, whatever you want to do. And then you have them read that back so that you confirm that they listened and understood. And then you document that and we move on, right? So that we move on by the first thing we're going to do is gram stain that blood culture. Okay, so collecting blood cultures means you collect blood from the patient and you put it into a media of growth and you put it in the incubator until it either grows or doesn't grow. Okay, so this was letting the doctor know if this patient had strep pneumo in their blood, so they're septicemia, right? Bacteremia, had the bacteria in their blood. That's not good. It's never good, right? Now, hopefully the patient was given antibiotics after you drew this and after we saw this and the patient started to get better and maybe the patient is well on their way to recovery, but now we know why they were running that fever and we now know why they were lethargic. We now know why they were having issues like meningitis because this is in the blood, right?
Will we get to do something like this semester?
Will we get to do something like this semester? I don't know, let me think, yeah, we can do something like
Do
this.
you think they give us stuff from the hospital or something if they have one?
I wouldn't go that far, but I could definitely, you know, I don't really need the hospital to let me know what I want to put in front of you. So I can set this in motion next week. You know, we can take a blood culture bottle and I can spike it with strep
Yeah, let's do it.
strep pneumo.
Let's do it.
Okay.
I mean, it's
All right. So this is, as you can see, this is blood cells that you see, your gram stains of your diplococci throughout. Okay. So one of my favorite slides to put on, like a midterm test, is to find this slide, but without any bacteria in it, and then pop it up there. And then you're going, oh, yeah, look at that. That's awful. Awful. That is gram negative garage, right? Because that's what that looks like. No, right? That would be like a normal. And I can always get you with something like that. So be careful on those midterms that you know what you're looking for.
we might do something.
Wouldn't do anything like that, no. All right, so Streptococcus, the species of Streptococcus in the family of Streptococcaceae, all right, is facultative aerobe. Uh-oh, that's different than what we had Tuesday, right? I had y'all define facultative anaerobe. So what? Who wants to define our facultative aerobe?
Sometimes the air.
Anybody in Zoom land want to jump in? So far in class, it's got sometimes air. That's where we're as far as we got.
Like it drives off oxygen, but better.
Drives off oxygen. When I get, there's a little hint here. You're not thriving on oxygen. So I'll answer that for you. The drive off increases CO2, which decreases the oxygen. That's where they thrive. So facultative aerobe means it's not obligate aerobe. Facultative aerobe.
They can deal with it.
Sometimes does.
Zoomland,
They can deal with it.
they can, yes. They're not changed. They can grow in the presence of oxygen. They prefer to be in a different atmosphere.
That's what I mean by sometimes.
Sometimes, yes, sometimes. Well, they can always grow in oxygen. They're not going to not grow if they're in oxygen. They'll grow much better if you take that oxygen out of there, put CO2 up. Okay, that's what it means. All right, so that name for that need my CO2 is capnophilic. Okay, so they love capno. They love carbon dioxide. That's what that means. So we have two ways of doing that. We can set up our incubators, and I can walk in the micro lab and say, this is my CO2 incubator. All right, and we're going to put just about everything in there. And then I have my oxygen, regular air, no air pushed in, just a regular incubator. And so we'll have things that we put in there, different of the same culture. Okay, we'll split it into different plates. And then you can go to the old school, what I always loved and what we did. We did it, when did I do it? Geez, whenever, oh, we grew those chocolates out, remember? Y'all know where did y'all see what I have? They might have already been out before y'all got there. Did y'all realize where your chocolates came out of? I pushed them into my candle jar. Okay, so we have a candle jar, which is a pickle jar. Old pickle jar, dill pickles come in. Y'all know, seen those maybe somewhere. And you put a little candle in there, all right? And you put your plates in there, and you light a candle, and then close the lid, and let them do, what does it do? It increases CO2 in that atmosphere. Okay, so I always like to say it burns off the oxygen in the jar, gives me a CO2 increase, and gives me my increased CO2. So I kind of create my own CO2 incubator downstairs, but we do have capabilities. We want to hook up to a big tank of CO2. I could do that. I could pump it into that incubator, and we could rev it up to 6% CO2. It'd be nice. Okay. So that's what that means here. Capnophilic. We can do candle jar. We can set up our incubators for CO2 being pumped in. And then here at the end, we have staph intermedius is an anaerobic strep. Okay. So intermedius meaning anaerobic, which means what? We're going to have to, if we want to see this, we're going to have to put it in our what? Our anaerobic chamber. Right? We have anaerobic chambers that take all the oxygen completely away, okay, so they can grow. And if intermedius doesn't like any oxygen. We learned this should be, yay, I know this now. We did a catalase, right? And I just almost like threw that at you over and over and over because I don't want anybody to be confused as to what they added to the slide to see it, right? I don't want you to come back and start missing it on a test and say, well, I added catalase to my slide and it just didn't, and that's not a choice. So I didn't get that question right, Mr. Director. I didn't see catalase as a choice. I think hydrogen peroxide was there, but you told us that we had the little vial had catalase on it. I dropped it on there, so that's hopefully you're not here. But a catalase reaction for strep is negative. So if you dropped it on there, you didn't get any bubbles, right? We didn't really have one of those because we had 2 staffs that we were checking out. But this week we'll have some strep in there. We can get one, and we have this one, and he shows up sometimes in urinary tract infections, which is Enterococcus faecalis, and he's weakly catalase positive. Okay? So he could have a little bubbly going on with an Enterococcus faecalis, but you, as the microbiologist, will know that you have Enterococcus faecalis before you even get going with that. Most are fastidious, and grow best on a media supplemented with blood. TSA, cryptic soy agar, you see that a lot. Got one called Todd Hewitt. We got heart infusion, usually comes in grain heart infusion, BHI here, and proteose peptone. These are some media that the strep works well with, pH 7.3 to 7.4. So we will see this. We may see him, but we'll see TSA. TSA is what you use on staph. It's what you used we saw the first day when you had your Staph aureus and your E. coli out that day. You saw that TSA is usually blood supplemented with blood, red blood cells, which changes it to red. And then it's usually TSA2 or something like that. But that's how it grows. So fastidious growth on supplemented blood agar. So it's nothing, if it's there, it's going to grow on the blood. Let's just put it that way. Classification. This is some getting deeper into something new. I don't know if you've ever heard of Lansfield groups, have you? Intro, micro, go over Lansfield groups with strep at all? No? Yep. Okay. So we have Lansfield groups A to H and K to B. Okay, so we have a weird breakout there. But it's a widely used system to identify the different streps. Okay, so we'll have group A strep, we'll have group B strep, we have group D strep. That's about the three that we play with. We play with those three. That the way they classify them is the antigens are different for different species of Streptococcus. And the cell wall is where those antigens are found. And you should have an idea of that. So these bacteria have certain things coming out of their cell wall that's different from the other one. And thus they can be classified into that group. They can be grouped into A, grouped into B, grouped into D. But when you hear Lansfield, and we're going to see why that can be confusing once you get to the hospital, because you won't be looking, well, you'll hear a group, but you'll be doing something else. And that's this. Okay? Hemolysis, what they do to the blood that's in the agar is the key to classifying them too. You put them as beta hemolytic or alpha hemolytic or gamma non-hemolytic organisms. So, question. So I go into the lab, I'm starting my microclinical, and they say, you know, we're looking for that beta hemolytic strep. And you go, okay, I remember Mr. Director talking about beta hemolytic strep. And they say, but we're going to use the Strep A kit. And they hand it to you. And they say, this is a great way of doing it. You're going to find beta hemolytic strep with a group A strep kit. Anybody see what letter is being bounced around a little bit, right? And that's the correct, right? Group A strep, the beta hemolysis, okay? And I know that's, for me, that was always like, well, that does, why would they put beta in group A, right?
Is group B alpha then?
Good question.
Since they want to get ranked for it.
Good question. Good question. We'll see that in just a minute. Great observation. So you take a Strep A detection kit, okay, and we take that. Anybody had the strep test done? Because usually every time you go to the doctor and have a sore throat, they do one on you. All right. We take the little rayon swab and swab the back of your throat. And if you're doing this, you know, you may not think you're going to have to collect, but you probably will have to collect. But just know that when you collect from the back of somebody's throat, you always go horizontal. If you really want to cause issues, just go this way, right? They will gag, and they might gag a little this way, but you can usually prevent the gagging if you'll just. My favorite thing is to tell people go tonsil to tonsil. And we're going to see pictures here, so we'll get to practice it with Tina. We'll get to do a virtual, we're going to see a big old throat, and we're going to do a virtual collection of the strep, okay? Get to do that. And then we take that little swab, and the nurse hands it to us, or if they collected it, and they'll say, okay, go do your magic. And then we go do our magic, and you're going to get to do this in immunology, you're there, okay? Which is, we're going to take the kit, and we're going to put like 5 drops of this and 5 drops of that. We're going to put our little swab in there, and we're going to leave it for a minute, okay? And what we're trying to do there is wash off the strep, okay? Those antigens we said we were looking for. And then we put that on a little test strip, or we put a test strip in there. I think that's the way we do this one. Put a little test strip in that after you take out your swab, right? And it runs up, the chromatography goes up like here, it goes up like this, and 2 lines form on a certain point, and you can tell the doctor that they tested positive for strep. And that takes 5 minutes, okay? Great, all right? Okay, that's our little test kit. That's our group A strep test kit. But the thing is that we're going to learn some things here in the micro class today that we still have to do, because if it was negative in that test kit, all right, you maybe heard this with the new COVID-19 test. You may have heard this, that if we do something for the antigen and it's not there, we have to call it presumptive negative. So that means now we need to do what we're going to teach you in class today, which is the micro part, which is to take that swab, or maybe 2 swabs, because you just washed it off in the stuff. So you kind of need 2 swabs, and you hate to go back and swab that throat again and make them throw up again. So you kind of maybe, if you're thinking ahead, you'll take 2 swabs in there with you, and you can swab somebody's throat with 2 swabs at the same time. You got to make sure they're even though, that they collect across and touch. And then you can take that other swab and you can put it on the plate, okay, and incubate it overnight. And we're going to put a little disc of antibiotic on there. And tomorrow when I open it up, and if there's a big zone of clearing, then I had baby strep, group A strep, and I can now say that the little kit missed it, and they're actually positive, okay? I know you're thinking that's really confusing and you got us lost, but that's the real process of doing a strep screen in the lab. Okay, if I take it out the next day and there is no zone of clearing around my little disc, but there's a bunch of alpha strep, then I didn't get my group B strep and it didn't clear, thus it's negative. See, my negative presumptive now has been proven negative the next day, and we're good to go. Now, most of you have had your strep screen in the ER and you got sent home. So what if it was positive? Well, the good doctor has already put you on something anyway, even though the screen was negative, and they put you on an antibiotic because they were pretty sure you still had strep throat. If they weren't, it could happen. But the test that we use for that rapid, I've never seen one miss, put it that way. But evidently, somebody along the way has seen one miss and has thrown out this idea that we must keep doing this. So it's been done for years this way. And I would like to say, hey, how many times do we have to see it not that way before we quit doing it that way and we trust our little kit and we get things done in 5 minutes and we're done? So I'll get off my soapbox now and come back over here. All right. So what does factor into the hemolysis, right? Organisms may be alpha hemolytic on sheep blood, just to confuse you more, right? But beta hemolytic on horse, rabbit, or human blood arteries. So we need to do what next week when we look at the lab? We need to make sure what is in our TSA, our tryptic soy agar with blood. What blood is there? Is it sheep? Is it horse? Is it rabbit? And I don't think it would ever be human. But it wouldn't hurt to check, right? So we can pull out what? We can pull out our handy dandy little info slip and we can see where the blood came from that was added to the agar plate. All right. But that's weird, right? We get alpha here on sheep, but we get beta on horse and rabbit. Group A strep, right? That's where we are in. Group A strep, which is beta hemolytic, produces 2 types of hemolysins, a strep O and a strep S. Okay? The great thing about strep S is that it is oxygen stable. The bad thing about strep O is that it is oxygen labile, which means the culture must be incubated anaerobically, or we stab the agar to put the organism in an anaerobic environment. Okay, so if you see a lot of throat swabs, you'll see that the tech is putting that loop of some strep in the agar with a stab. But remember, O is oxygen labile and S is oxygen stable. we have this one, and Sherman-Based is a class of name. It's a group, okay? It's a group of strep that includes Enterococci and viridans. But kind of the way it's evolved is that most of these are considered viridan strep, okay? So we see that Enterococcus is a part of the GI tract, right? We talked about Enterococcus faecalis earlier, and that's why it would be a UTI, right? Because if it's in the GI tract, most of our GI bugs can end up in the urinary tract and cause an infection. So that's why I'm saying you would see Enterococcus faecalis in the urine culture. Strep viridans or viridan streptococcaceae is normal flora, and that's what microbiota means, of the upper respiratory tract. Okay, so we would see viridans if we were doing stuff like sputum culturing. We may see a strep viridan there. So what do these things look like? So again, not to, make you spell things, but the S in front of pyogenes and the S in front of Galactiae, I put my L in front of my A. A Galactiae, if you want to keep going, right? Remember that may be confusing to some new microbiology students because you still may not have these grouped up into staph and strep and make the determination as to why pyogenes is in a strep and not, and you may, if you were spelling it on a midterm, Mary, you may put staph pyogenes there, and that would be incorrect. So to make sure you don't make that mistake, I'll spell it out. I'll put Streptococcus pyogenes on there, and you'll be able to pick that strep off the list for a group A strep. So this is our strep throat. This is the one that causes strep throat. Typically produces small transparent colonies with a large zone of beta hemolysis. So we're going to see these, but we're also going to see a group B strep. Okay, group B strep that we typically see with our pregnancies. Okay, if you were pregnant, you went into the hospital and they hadn't checked this yet, they would check for a strep B in the birth canal. Okay, and they probably would have done it with some kind of quick indicator test because my wife got this done like, I don't know, an hour before birth. And they said, oh, you're group B strep positive. Before you let that baby come through the birth canal, we need to do what? We're going to hang a bag of antibiotics on you and have it infused before that baby's here, right? Because they had to introduce that to the birth canal to hopefully take care of the group B strep. We'll see that the hemolysis is still beta hemolysis, but it's going to be smaller zoning. And then we have Enterococcus species typically, which are large, gray, translucent colonies, and they can appear as alpha, beta, or non-hemolytic. So we kind of get a mix up here, but we have our group A and our group B up here. And we're going to see pictures in just a second when I flip the slide. So you see the stabs up here. Okay, so this is the group B showing a large hemolysis. Group A. Group B in the middle showing less hemolysis. And then group D over here showing no hemolysis or very little at all. So you're like, well, how can you tell if that's beta, that's alpha, but it's clearing. So beta clears, okay? And clearing, a little closer, is here. So this is strep pyogenes, group A strep, and you can see that zone kind of looks like who? Who does that look like? Who did we see last week? Tuesday that looked like that. You saw it. Yeah, you saw Staph aureus, right? Staph aureus had the beta hemolysis, but a lot of our plates were what? Clear. Y'all noticed that when you looked at it? Said, oh, look at it up at the light. And the blood was gone, right? It wasn't any of this golden lysine. It was just like clear zone, okay? Keep that in mind. It's total hemolysis, right? But this is where if you had this and you were like, oh, I'm new to this, I don't know if that's strep or staph, right? I kind of need to know, because if I gram stain it, yeah, it might look, it's going to be positive, but it may not be as good in clusters as chains. So I don't, what's the quickest way I can do that test? What can I do real quick to find out what I got? Beta hemolytic. It's either staph or strep. So do I have strep pyogenes? Do I have staph aureus? What's the test I'm going to use? I'm going to pick it up, put it on the slide real quick. And I'm going to grab a little, the catalase test. I'm going to grab some hydrogen peroxide. I'm going to drop it on there. And if it doesn't bubble, I got it. And if it does bubble, that's staph. The good thing is that I'm going to go ahead and set it up on a gram-positive ID panel, regardless, right? Because we know it's gram-positive, it's growing. But if it was a wound culture, yeah, we would be gram staining it, and we could have strep there, but more than likely it's going to be staph. So again, group A, beta hemolytic. Here's the group B, strep, still beta hemolytic, okay? Nothing's changed, it's not alpha. Okay, it's still golden, it's still clearing, but not near as pronounced as far as the colony. Look, that looks great, right? Most of y'all's staff look like that on Tuesday, right? And then here's our Intercoccus faecalis, okay? So all of a sudden this one pops up really small, and that's usually a real indicator you're dealing with strep instead of staph. The colonies have gotten a lot smaller, okay? And that's when you can usually go, I've got a strep here, so I know I really don't even need the catalase test. If I wanted to do it, I could. And then this is Intercoccus faecalis, which is in the GI tract, and this is probably from a urine culture at this point. Here's another Intercoccus called Facium. Again, no hemolysis. Or maybe some hemolysis, right? Remember this little statement. Let me find it. Intercoccus species produce large gray luminescent, but maybe alpha, beta, or non-hemolytic. Well, that looks like maybe some around, maybe a little alpha around that. And alpha kind of has a greenish tinge to it because it's incomplete. It's not really clearing the red cells. It's fragmenting them a little bit, but it's kind of incomplete hemolysis. All right. So as we move, we've moved. Let's see where we are. How we doing in Zoom land?
We're good.
Good. All right. Viridans strep, very small, opaque, domed, and they may be alpha or non-hemolytic. Okay. Pneumococcus, very young colonies, are dome-shaped. Let's be strep pneumo. Olders may be umbilicated, meaning they depress. And we got a real good slide to show you that. But they have this capsule above them. Okay, they have a smooth mucoid capsule. We call them a mucoid colony. That's our pneumo. That's our strep pneumo. And then you can see that umbilicated over here, kind of pits, kind of a pit in it. And you can see the newer ones over here have the big mucoid over the top, okay? On blood auger, you can see the mucoid, strep pneumo. So what would you call that color? Strep pneumo. Did we cover this already, or did I miss it? Who's this? What hemolysis is strep pneumo? Did we just have it, or did we not pay it, or we not remember it? What hemolysis would you call that? Real good picture.
Alpha.
Classic. Alpha, yes. Alpha hemolysis. So you can see that hopefully you can tell that's a greenish tinge to it. There's the pitting, the umbilicated. Looks like a meteor's hit, boom. Diplo, right? Streptococcaceae. No, just not a gram stain, that's a column. Here is sanguinus. This is a Viridan strep. Again, very small colonies. Okay, very, very. This gets you. This is when you go, well, heck, we're looking at alpha hemolytic strep, but I just got to make sure it's not strep pneumo, right? Because we know strep pneumo is probably the pathogenic version of the alpha strep. So you may have this, and you're going, well, I'm pretty sure that's not strep pneumo, but we'll do a test to see if it is. And we're going to put these tests in just a little bit. So keep a little preview of, hey, I've got strep sanguinus, and I'm not really sure if it is. I'm not worried about strep sanguinus. I'm not going to set that up. I'm not going to ID that. That's an alpha. It's going to be hard to ID, and I'm kind of giving you some hints to micro. Streps aren't always the easiest to get ID. So we do a lot of different things to ID them. And this is it. Okay, so I kind of previewed into the ID section, which is Group A strep, our strep pyogenes that we've already linked together. So we're good. We're on the ball with our streps now. But we're going to take a bacitracin. And how many of you know what bacitracin is? I'm sure you never ever like cut your foot or your hand and you got some ointment out of the cabinet. Your mom said, let's put some of this on there. Okay. Usually it's bacitracin is in there. It's a topical antibiotic. And it usually comes in ointment form for us. But the good thing is strep pyogenes is susceptible to it, which means that it will not allow strep pyogenes to grow on our plate if it's present. And we're going to make it present by putting a little taxo disc right on where we just made our streak for isolation. We're going to lay that disc in there and flip our little inoculator over and push it in just a little bit, but be careful, don't bury it, just lay it on the top where it doesn't fall off when we turn it upside down. So yes, we will be doing some of this on Tuesday. I'm trying to give you a preview of what we're going to be playing with, bacitracin disc. The organism exhibits a zone of inhibition, which means that when we did that swab that we first talked about with test from the kit test, and the kit was negative, but we had to say presumptive, and I went and did the swab in the micro lab, and I put this disc on there. That's the reason I did it. If there is no growth, meaning that strep should grow all over that plate. Okay, should cover it up. But when I put the disc in, it kind of diffuses that antibiotic out around it, and the strep won't be able to grow around the disc. So you'll have this zone in your agar of no growth around and it's called susceptibility. So that is susceptible and resistant are our two words that we'll play with antibiotics. So that's our big check. So we definitely put that bacitracin on there. And the good thing for us is that the disc has a big letter printed on it, so we don't get confused. And it's called P-disc. Okay, why do you think it's called P-disc? Not because it's bacitracin, but it's what? It's checking for pyogenes. Okay? So we put a little help there. These are the groups, septus, representative spectra. And then we have this at the bottom. I think is that in your notes? Yes. The PYR, okay? PYR hydrolysis, it is strep A is positive for PYR. So who can tell me what PYR is? Because I don't think I gave it real good intro in the, oops, did I say P disc? I did, didn't I? Oops, it's an A disc. Sorry, I got ahead of myself. Whoops. It's an A disc for what? Sorry. Sorry in Zoom land. It's an A disc for what? Group A, sorry. I got ahead of myself. We got a P disc coming up, sorry. So we'll have to see how easy it is to get confused. So I even got confused on my P and A disc today.
Wait, what?
I got confused. I said it was the P disc instead of the A disc for strep pyogenes. Sorry. And that's recorded, so if y'all want to use that against me later, you can. All right, so we got to answer this question as what is PYR? Right? It's in red. Who's got me? Who's helped me out there? Pyrrolidonyl beta naphthalamide hydrolysis is positive with this test. I know somebody's quickly trying to find it for me. It's also a disc, right, that we can put on there. And it does turn red, okay, if it is positive. Y'all ever used like a little disc? I think I've seen one. Y'all haven't done urines and body fluids yet. I'm trying to think of the ketone test. Is anybody familiar with the ketone test? Putting serum or urine on there and it turns purple when you put it on there. It's kind of an indicator test. Well, that's what PYR is. It's a little disc that's impregnated with pyrrolidonyl beta naphthalamide. I'm not going to have you have to know that at all. Just remember PYR. But if this organism can produce, right, the enzyme that breaks that down, hydrolyzes it, it's considered positive. So group A, Streptococcus pyogenes, is considered PYR positive. And what I'm going to share with you is a little, I think this is emery. I think it's emery or Loyola, somewhere. But I've got a little, do y'all love these or not love these kind of things? And then, I know Zoom can't see it, but it's a picture of a flow chart of identifying organisms based on all the reactions that we're talking about. Okay, so we have this whole section here, right? Here we got strep pneumo, we got viridans, we got pyogenes, we got Aglapiae, we got Enterococcus, and group D strep. All of this side over here is based on beta hemolysis, alpha hemolysis. So it flows out to the side and gives you who you're dealing with. So I think if you want to really give you these, so if you're studying, you can start at the beginning. Gram-positive, cocci, okay? So it starts here. Cocci moves to catalase. Catalase negative, we move, to the streps. Catalase positive, we move to the staph, okay? Everybody kind of got a feel. There's two. There's one for gram-positive and one for gram-negative. I think it'll be great to help you study. All right.
I said this was chapter 12.
This is chapter 14.
Chapter 12 has a lot of the tests in it too.
Yes, I knew there was another. I was looking for that earlier, but yeah. So there's
pictures of it, like purposes.
Oh, there is. So what page are you on?
I'm on 241 for that QL.
Yeah, 241, right? Great. That was what I was hoping somebody would do when I was buying time. So way to go. All right, so yes, those that have the big book, you can see it on 241. So you see that it's great for strep pyogenes and intercocci. And what they do is that they have the pyrrolidonyl arelamidase, the enzyme there that breaks that down and turns it positive in A versus B. Okay, so that's one of our go-to tests. So chapter 12, that was a chapter I was really looking for that shows oxidase. It shows the P disc, which we're getting to in a little bit, but we were really on the A disc. All right, where's the A disc in here? Maybe I missed the A disc. Yeah, there's P. Don't see an A. Okay, well, we have A. Let's go to A. There it is. There's the A disc. So what's the antibiotic that's in the A disc? Zoom, you can answer.
Bactylo, whatever that is.
Bacitracin.
Yeah, that's it.
Okay, so look at the zone of clearance. So here's my strep. I just streaked that swab on the patient, right? I entered it somewhere and then streaked it with a loop. But here's the zone, okay? You see the zone around the disc of clearance. So that lets us know, I didn't really have to know that was strep pyogenes, right? I didn't have to finish that diagnosis out. I didn't have to get an official growth report before I was able to say, we're A disc positive. We're sensitive to bacitracin. Okay. Now, yeah, are we doing okay? We're right at 12 o'clock. We got 15 more minutes. We're doing good, right? We ain't got to our good pictures yet. Group B strep, Streptococcus, a galactia. It has a couple of tests, and we have one known as the CAMP test. That's the one I'm going to focus on. It also has hippurate hydrolysis, kind of like the PYR hydrolysis. But it's the CAMP test. Where is it? I think it's in chapter 14. I think it actually has a picture. Yes, CAMP test is on page 276. Positive CAMP, okay? CAMP stands for, this is a big trivia question you get right one day. What does CAMP stand for? Anybody know? It's about 4 names.
Christy, Adkins, Munch, Henderson.
Yes, so 4 different people probably came up with this one time and they named it after themselves and called it the CAMP test. But what you do is you take Staph aureus, okay, remember our Staph aureus? And you streak Staph aureus across the plate, and then you take your unknown streps and you put them perpendicular to the staph, and then you'll get a zone of enhanced hemolytic activity for a positive hemolytic strep, okay? No hemolytic strep here. There is some here. You see the A disc here. Okay, A disc not doing anything. I guess it's not, can't tell. But anyway, that's the CAMP. So that is positive for GBS. What does GBS stand for? Group B strep, yes. We're not very, we can be simple sometimes, but GBS is a group B strep with a CAMP test, and we're going to try this too on Tuesday. So we'll bring out some of this and see if we can't repeat the CAMP.
That one's on 213.
On 213 too. Okay, good. That's the procedure, right? On how to do the CAMP test. So again, your Bailey's and Scott is just filled with great info, but not always in the chapter where we're focused. That's the take home. So that leaves us with group D. I tell you, we talk about A and B, and then here's group D. Normal microbiota of the GI tract. These are our intercoccus. Okay, so we have intercoccus and not intercoccus. And what makes an intercoccus, this is our faecalis and our fascium What makes them different than the non-enterococcus is three things. Esculin hydrolysis, 6.5% sodium chloride growth in that broth, and PYR hydrolysis again. So PYR hydrolysis shows up again with group D. Where did it show up before? Went the wrong way. Right, group A. Okay, so here's some things that definitely is test questionable, which means that when we set up a test, I can put all the following are, can differentiate group D enterococcus from other group D. Here they are: esculin hydrolysis, 6.5% sodium chloride broth growth, all of that positive. And we just don't have the time to go through each one of these, but they're definitely book worthy. You can definitely find them as far as showing up and talking about. We talked about the PYR. I think the others are explanatory. Salt, sodium chloride, and then esculin we'll get into. I think we get into it today with our API. I can't remember if esculin's on there or not, but here's another group D that's not enterococcus, and this one's used a lot of times for control. So a lot of times when we're IDing streps, this is a basic strep bovis, okay, and you see it sometimes growing in the control group of non-A, non-B strep, okay, in group D. Viridans versus pneumo. We know viridans is what? What group's viridan? Do we know a group for viridan? Have we grouped viridans, or is viridans in its own group? Great question, Mr. Director. A chart for us. Optogen susceptibility. Strep pneumo. This is where we bring in my P disc that we were trying to talk about earlier for pneumo. And I pointed right to the second version and said it's a P disc because of phylogenies, but I meant P disc for pneumo. So we'll actually, for strep pneumo, we can actually set up the strep if we don't know if it's strep pneumo or not, and actually put the P disc for strep pneumo on it, and that has optogen antibiotic on it, and it has a zone of clearing if it's pneumo. So a lot of times you might see, I don't know what strep I've got, so I might just put an A and a P on there. See if I have strep pyogenes versus strep pneumo. I've seen that done. We can also do immunoserological ID. We'll do this in immuno. We can do latex gluten test. We have a group A direct. Then we have culture confirmation for A, B, C, D, F, and G. Okay, so we can actually look for agglutination for strep pneumo. We can do fluorescent antibody for strep pneumo. So there's different ways of finding strep pneumo. Here is the fluorescent antibody testing. This is foreign language to you right now. We'll talk a little bit about it. This is not very readily available in most micro labs to do a fluorescent antibody. And then we get to the fun part, which we work so hard to ID it and talk about how we ID and how we test for them, that now we get to talk about the clinical significance of all of these. Group A strep, strep pyogenes. Oops, where did I go? Oops, there we go. Upper respiratory tract, pharyngitis, sore throat, strep throat. Also a cause of scarlet fever. It can also, Heather, cause impetigo. And it can also cause inflammation of the muscle known as myositis.
I only asked that because my 7-year-old got it like twice when she was younger, and it was awful.
So now if we took a little swab and went in that little sore and came back and we swabbed it out, we'd know whether it was from staph or strep. I don't know if they did that. Probably not. Probably just put antibiotic on top of it, let it
Yeah,
go.
they gave me antibiotic ointment and she had antibiotics on out too.
So clinical significance of the strep, which one are we on? Pyogenes? Suppurative sequelae, meaning pus-producing infections, and we get complications in the upper respiratory tract. We get peritonsillar abscesses, so you will see pus pockets, as they call them, in the back of the throat. You will have otitis media, which is inner ear infection if it goes unchecked, and definitely causing sinusitis from being there. Non-suppurative sequelae, meaning those that don't have pus form, would be autoimmune disease associated strep A. So we get glomerulonephritis from a strep infection if it prolongs and untreated. And we can also go to rheumatic fever, okay, which is when inflammation moves through the circulatory system because of this infection, and the heart is the main focus there, causing valve damage and turning into murmurs. Okay, so definitely can lead to problems. And you can hear, you know, maybe your grandfather, grandmother talk about having rheumatic fever when they were little, and that's why they have their heart murmur, and that's why they have to go to the doctor all the time to get it checked. Pharyngitis is definitely sore throat. It can turn into rheumatic fever and kidney infection if it goes unchecked. We see a lot of strep in school-age children, and it's transmitted by respiratory droplets. Sore throat, fever, and tonsillar exudate is definitely what we have. That's why if you show up with a sore throat, you get a strep screen, especially if you're smaller and younger. And there is our, here we go. We're not wearing any gloves, but this is an old picture. But I have used the old tongue depressor to get that mouth open because most kids aren't willing to do that for you. Some will, but some don't. Sometimes you have to do babies, okay? That's never fun either because the worst thing you can do is cause them to gag, cause them to throw up. They aspirate on their vomit and they end up in the ICU because you couldn't do a strep screen correctly. I know that's harsh, but that's could happen. There's our practice. I said go from tonsil to tonsil. So I like this one because it's swollen tonsils to tonsil. And your tonsils lie right in here, right in here. So what you want to do is get back here and just go whoop, whoop, and be done. Okay? If it's strep, you'll pick it up and you'll transfer it very easily back to the lab. But that is definitely a red hot throat and tonsil swelling. Again, these pockets, okay, all of that irritated, go back in here, there's the tonsils, and we've practiced. Scarlet fever produces an erythrogenic toxin. Early symptoms of the sore throat and skin rash. Skin rash is a good indicator you've got a strep infection. Begins on the chest, so usually the doctor pulls the shirt up if they don't have their shirt and looks at their belly and looks around for any red rashes to help them indicate that they do have a strep infection. Once the rash fades, we get the peeling of the skin. You know, even the tongue can be beefy red, moist, and glistening. The rash, that's kind of hard to see, but there's a better one coming up. The impetigo is crusted lesions on causing a superficial infection, cellulitis. Diffuse skin infection on the face is this erysipelas. It's kind of like a mask, the irritated muscle. And then we get to the last one here of strep pyogenes, could lead to necrotizing fasciitis. It's not the only cause of flesh-eating bacteria, the way it gets its name, but we can have toxicity and death. And this is just giving you a heads up that we're seeing more and more cases of it since 2010. The etiology could be reason. There could be other causes. It could be Strep hemolyticus. It could be MRSA, right? Community-acquired MRSA, CLEB, Enterococcus, Aeromonas, Hydrophila. Vibrio, we see this sometimes down in the Gulf. When somebody says, oh, I went into the Gulf and I came back with a flesh-eating bacteria, right? Could be Vibrio from pollutant water that's pushed into the Gulf from the sewage systems of those cities down there. And then we have some bad, gross out pictures. Just to give you an idea of what may happen if you end up with necrotizing fasciitis. Rheumatic fever, on the other hand, involves heart, joint, subcutaneous tissue, more like an autoimmune disease. Basically, it's a cross-reactive with the antigens from strep and human tissue. So your body forms an anti-strep antibody and starts to whack away at your heart tissue. Not a good thing. Early, as it's from the strep throat that ends up with the rheumatic heart disease. Usually 6 to 15 is where it develops. Post-strep goes into acute glomerulonephritis. This is kidney. Okay. Those immune complexes end up in the kidney. Kidney's not happy to have immune complexes in their circulating tissue, and those stick in the kidney. And when they stick in the kidney, they start to cause kidney damage. So we have big, big issues there. Those are the main two things: rheumatic fever, acute glomerulonephritis, necrotizing. All those play the clinical significance. We have our virulence factors. We said we had O and S, right? So which one is oxygen tolerant? Y'all remember? You knew I was going to come back to it. S. O's not, right? So ASO, the one we would do, anti-streptolysin O, since it's not very tolerant to oxygen, we can actually screen for the streptolysin O production. If we find it, then we can run a test and see if it's present. So it tells we had a group A strep infection. Big numbers on 600 million illnesses a year. Whew, that's a lot. 500,000 deaths globally every year from strep. The virulence factor, big red letters here for you, is the M protein. The M protein in the cell wall is the main virulence factor of strep. Group B strep. Streptococcus clinical significance. We've already talked about it. It's the group B strep infection of the mother. 1 in 4 women have it present in the vagina. So if we have a real live birth that runs through, then we have an issue. And they're given antibiotics to protect the babies. And if you've seen the baby comes out, they give them the big swab over the eyes too. Like anything that you may have gotten through that birth canal, they try to medicate, but one thing they really can do is go ahead and put an IV of antibiotics in the mother, and that usually neutralizes the strep that quick. Usually it's from low resource settings where we don't get that treatment, that we get preterm births, we get infected births, we get babies that have sepsis and meningitis because they went through the birth canal that way. Neonatal sepsis, the word you're looking for your notes. High mortality, 75%. Late onset, better mortality, but still a mortality rate. And this, it's lunchtime. I know some of you are coming to the lab, but you can read this on your own. I'm not real big on placental ingestion, so I'll just skip over that. If we had more time, we'd spend 5 minutes talking about it, but we don't. So here's the erythema and the edema. Here is a strep galactiae acceptability E-test. An E-test is for erythromycin, another antibiotic test. So here it is here on the strip down here. So they could take this strip, right, place it on the plate, see the zone of clearing. Urinary tract to a wound infection can be Enterococcus faecalis, the D, or facium, the ones we've talked about. And I think we're about done. Oh, we still got strep pneumo. How are we doing on the slide? We got about 5 minutes. How we doing on the notes? Where are we?
On the back.
We're on the back and we're right at strep pneumo. Oh, we got 5 minutes. I think I can get this. This is clinical significance. So strep pneumo, most common cause of community-acquired bacterial pneumonia. So we got strep throat with strep pyogenes. We got pneumonia with strep pneumo. Also is common cause of inner ear infection, otitis media. And then we can talk about being a carrier, right? You hear a lot of that from last lecture on MRSA. The organism colonizes our upper respiratory tract of a healthy person, but we may spread strep pneumo to somebody else that's not, could be susceptible to it. It's diplococci. In the sputum, we see a bunch of PMNs. Those are polymorphic neutrophils, whatever, right? What was it again? What's a PMN? Yeah, we got hematology. What is that? You hadn't got to white cells yet?
Polymorphic neutrophils, right?
Yes, polymorphic neutrophils. Thank you. Virulence, it has that capsule. We already talked about it, so that's a review. And we do have vaccines available for strep pneumo. Okay. So if it's the biggest cause of bacterial pneumonia, what do we ask our patients when they come in? Have you had the pneumonia vaccine? Now you know what the pneumonia vaccine is for, right? All right, bacterial. Viridans strep is normal for the upper respiratory tract, normal flora, but it can lead to endocarditis. And one of the things here to finish up, because you may be going to the dentist soon, and if you get antibiotic prophylaxis, that means you're going to have like some kind of aggressive, a tooth pulling, a root canal, and they'll put you on some antibiotic before you come in, because they're trying to knock out the strep viridans. The one they're trying to knock out is known as strep mutans. Okay, this one causes cavities. But if it gets introduced into the bloodstream, then it gets to go to the heart valve and it sets up there and grows there. So we don't want that. All right. And I think that is all I wanted to talk about was the strep mutans at the end, and that's a viridan strep. And you might have a patient that had to get on prophylaxis. Okay, did real well. We spend a lot of time on what I want you to focus on, which is that micro part. I'm not training you to be doctors. You get the doctoring part as you work and as you learn your patients. But it is fun to know how these connect to real life patients. But your work is up front. Your work is knowing those tests, knowing what it looks like, gram staining it, IDing it, sensitivities, all that. That's your take home, okay? So don't try to figure out the sequelae of the disease and a little bit more up here testing side. All right, we'll see you downstairs in a few for lab.